Pleasure to be here with all of you, clinicians mostly. I guess you're all physicians and nurses, but I think Nithya was mentioning about having a broad perspectives from UNAIDS and then from PEPFAR, USAID, and then WHO. But I think what brought us together here is that in some instances, we're all patients, we're all providers, we're all service receivers, and then we are the recipients of the policymakers. So all of this connect us together. The issues that we're bringing to you today is going to touch us in different areas, in different aspects of lives. So I hope you will take this home, and then we hope that the sessions that you hear today will give us all some thoughts and enable us to change for better practices in this region. So with this, today I'm talking about transitioning from international to domestic funding and highlighting some experiences in the Asia-Pacific region. So I am the senior technical advisor from USAID, and USAID received funding from the PEPFAR, which is the US government, providing funding to over 60 countries in the world. And in Asia, we're covering 11 countries that we're working together and connecting with each other and learn from each other. So the outline of my talk will also include funding gaps of the HIV response, which Eamon has already mentioned, but I will focus it a little bit in terms of practices and promising models. I will also talk about barriers and bottlenecks for transitioning in some countries, and then suggesting some ways forward. So PEPFAR has recently set up a regional strategy in Asia covering 11 countries, including Central Asia and some countries in Southeast Asia and Thailand, Laos, Burma, Cambodia. The strategy is really to try to reach 90 targets of UNAIDS and try to achieve full PrEP access to the highest risk populations or KP by 2020, and aiming to eliminate AIDS by 2030. With this strategy, USAID program will focus on expanding key population networks, key population-led and community-led approaches for service delivery. We will strengthen key population organizations' participation and leadership with the hope, anticipation that they will help to sustain the epidemic control. We will also aim to advance regional connectivity, enhancing country learning from different practices. We will also continue to support a country's journey to self-reliance from international donors, and that includes working to increase and optimize domestic investments for KP programming, as well as innovate financing mechanisms. Ambassador Birx, who is the lead of the PEPFAR programs, has said to us many times, civil society plays a critical role in the HIV response, and that was also echoed by UNAIDS earlier. We would not have been here today without their leadership, their activism, their advocacy, in order to allow full coverage for treatment in many countries and allow prevention programs to happen in many countries. Yet, support from donor is really inadequate, highlighted also in the UNAIDS presentation. If we want to do fast track for ending AIDS by the years that set forth for all of us, we need to work with civil society and put the effective tools to the hands of the people who will know how to reach those populations, and they are facing the greatest needs in terms of HIV prevention and treatment. What are the rationale for financial transition? So there are really high levels of donor dependence on HIV funding in the region, and particularly for KP programs in many countries in Asia. The program's sustainability and inclusive national coverage ultimately require full domestic financing, including government budgets and private sector funding. And domestic funding is increasing, but it's really inadequate. Current donor funds are time-bound and limited, and I can say from a lot of experience, if we face political issues, funding is really vulnerable. And if in some countries donors leave without saying goodbye, really, they will leave, and then who will have the effect most will be your patients, your clients, and in some cases would be your friends, your colleagues, and your communities. So we really need to take the transition approaches very seriously and plan early. The future outlook for donor funding is really uncertain. In many cases, they are unreliable. So I borrowed a slide from UNAIDS just to highlight that we are really reliant on the international resources, except a few countries on the right-hand side, starting from China, 0.3% dependent on international funding, Malaysia 3%, and then Thailand 11%. So these three countries will be the closest to sustainable financing for HIV program. So I borrowed also some data from the Global Fund Shift program, which looks at the national HIV financing situations in 4 countries, and that are Indonesia, Malaysia, Philippines, and Thailand in 2017. There's been an increase in terms of domestic financing of national HIV responses, so data are consistent across, with Malaysia highest, 96%, and Thailand second, Philippines and Indonesia. In aggregate, only around 10% is really spent on men who have sex with men and other key populations, and we know that these populations are the center of HIV epidemics. The bulk of HIV prevention spending is really, on KPs, is really from the international donors. Civil society faced a lot of challenges in accessing domestic financing, and this has been a significant challenge in all countries except Malaysia, and I will tell you later why. In Indonesia, MSM programming received 99.7% of their funding from international sources, and in the Philippines, it is 100% for MSM. International partners usually provide direct funding to CBOs, and if they have difficulties, and if international donors leave, not to mention abruptly, they will face a lot of issues in terms of addressing HIV epidemic in their countries. What are the barriers and bottlenecks in transitioning? Countries are really at different places when it comes to transitioning. Transitioning from external to domestic financing has been constrained by the lack of political will, stigma and discrimination within the society and within the government. There are competing priorities. Private sector is at an early stage in many countries, and in some countries it's really limited. Engaging them in the strategic planning has been far from ideal. Data are quite limited on how money is spent, and if we have limited resources in countries for HIV programming, we need to know whether those are spent efficiently. Traditional government health budgets are often, or whether they are decentralized or centralized, they are often not well adapted to provide funding to civil society organizations or community-based organizations or CBO to support health service provision, particularly for key populations. And I would like to highlight a few reasons for that. There has been an absence of enabling laws and policy in many countries in Asia. And government attitudes toward civil society organizations may include lack of trust that they can do HIV programming in a quality way, and there are concerns of financial management and governance, and there's a lack of ownership. A lack of ownership, what I mean is that in many countries, sometimes money, if it's not given to the government directly, then it's not considered given to the country. Are you following me on that one? So we face, in some countries, if we provide funding to civil society organizations will also face resistance when they do advocacy, saying, you have the money, you do it. So it's as simple as that. We need to address stigma and discrimination and attitudes towards financing among the government officials as well as the society at large. And when there are policies and mechanisms for financing civil society organizations, in some countries, Philippines included, there are really stringent registration criteria. In many countries, it takes years, multiple years, for an organization to be registered and eligible for receiving financial support. And there's an issue of civil society organization accreditation, whether they are certified to provide HIV services at the quality of that the government or healthcare providers will satisfy. And then the credibility of civil society organizations and whether they have technical capacity to address and provide services such as PrEP or treatment support and things like that. So here I would like to introduce to you the social contracting mechanism. So the social contracting mechanism that allow for government to provide funds to flow directly to civil society organizations in order for them to implement specific activities. And these social contracting services really aimed at ensuring that when the fund is flown to civil society organizations who are supporting the HIV services across the cascade, they can provide those services at a timely manner and and most efficiently and most effectively in order to reach their communities and their friends. So these are some examples of the countries that are implementing social contracting approaches. In Asia, there are quite a few countries, including China, India, Malaysia, Thailand, and Vietnam. So, and these are examples of some countries. Malaysia, I mentioned earlier. Malaysia, traditionally, they have responded to the HIV issues from their own funding from the very beginning. Although there may be some challenges in terms of setting or putting investment for key populations in this country, given structure and system barriers in the country. In India, financing mechanism has been decentralized to the hands of the state aid control societies or SAC, and at district level, district AIDS prevention and control units. In China, they are almost self-sustained, and that has included the fact that if the government wants something, they can do it. Someone told me if they want to build something to compete with India, for example, China can do it in a day, and India can do it in 10, 20 years because we have a democracy, and then we have to discuss and we have to participate, and then we have to. So in China, when the government wanted to do it, when they wanted to finance civil society organization, they can do it. So they have set up a government-led NGO to help support implementation of HIV activities, and the government at the provincial or state level have really taken initiative to continue to provide HIV services. So Thailand, which is the country that is closest to the sustainable financing. So these are a clear example of the government entity. In this case, is National Health Security Office, who has provided universal coverage for the Thai citizens for very lower cost. And in terms of HIV, they have recently established a prevention fund focusing for HIV prevention activities for key populations. So you can see the red bars. There has been a significant increase in terms of financing for civil society organizations since 2016. And that the success of that involved establishing systems and legal frameworks for enhancing contributions of KP community-based organization. It also includes setting up accreditation system and reimbursement processes that involve different models that are tailored to sometimes at the different levels. At the provincial level or district level, wherever they feel comfortable in order to finance these organizations, then it can happen. And then there is a management of civil society organization contracts through provincial subgrants. And then the final one, recently NHS, National Health Security Office has approved the inclusion of PrEP in universal coverage, although it's called a demonstration or pilot of about 2,000 cases to be included under this. But I think this is a promising sign that later PrEP will be fully covered by the national government. The challenge for Thailand is then when civil society organizations are receiving funding and providing HIV services across the cascade, what are the costs for them? What are the costs that the NHSO are willing to pay? So there are still ongoing work in terms of analyzing the cost, unit costs and cost effectiveness of each service delivery option. Ranging from HIV prevention, outreach, HIV testing, and PrEP provision, and even ART dispensing in order to inform the national government for appropriate pricing of these services. So I mentioned about PrEP being one of the key strategies for PEPFAR. So PrEP has been really one of the main success in Thailand. In the 11 countries, Thailand is the only one under PEPFAR. Thailand is the only one country that is really implementing PrEP, and that is due to the USAID linkages program as well as the Thai Red Cross AIDS Research Center providing PrEP using key population-led service delivery model. With that, key populations are trained to provide PrEP at the community level. They are believed to have been able to reach the populations that are in need of HIV prevention, and we were right about it. The evidence that we have generated from different implementation science activities have told us that they are willing to come to the community-led sites, and these are located throughout the countries in 9 key population-led sites throughout Thailand. So the number that shown here, which keeps increasing by on a weekly basis, and we are monitoring that. The key population-led model have contributed more than half of the national uptake of the HIV testing in the country, and in terms of PrEP, they are the main provider for PrEP in Thailand. And on the left, your left side, and that is the data that we have from the public sector. So we still see that they are keen on providing, on receiving PrEP from their friends and their communities rather than healthcare providers. So this is part of the task shifting strategy, and that also requires collaboration between community-based organizations and healthcare providers at the hospitals. So it's not, so nothing on this slide is done in isolation, but it's the emphasis on the service provision is different. So this is also showing that the PrEP provision by the communities have supported the country in order to reach the national target. But in order to reach that, we need to scale up even faster. The UNAIDS has set the target for Thailand to have about 100,000 people to be receiving or provided PrEP. And in order to get there, we need support from civil society organizations. And on top of that, you see on the right-hand side, PrEP to be included in USC. Without that, some people are still facing challenges in terms of affording to buy PrEP in their locations. So we're going to need to ensure that they receive free PrEP. But what I want to show here is to discuss with you how we got here to have PrEP finally financed. So this is the evolution of PrEP in Thailand, starting from having research studies done since 2010. And then there have been implementation science to show, to generate evidence and show policymakers that it is feasible for PrEP to be provided by key populations and by community-based organizations. And there are initiatives from and advocacy from the Thai Red Cross, as you can see. And on the right side is the Princess PrEP program supported by USAID linkages program and implemented by the Thai Red Cross. The reason it's called Princess PrEP because the Princess Somvali of Thailand has graciously supported free PrEP while we're waiting for PrEP to be covered by the government. And this has the additional benefits that it helps to connect the public, that they can also provide donation to support key populations, and that also largely reduces stigma and discrimination in the society. So what are the steps towards successful transitioning in Thailand? So there are issues with resistance among the physicians, among the professionals, medical professionals, including medical doctors, medical technologists, and nurses, and pharmacists, in order to allow civil society organizations to provide HIV testing, even finger prick. Thing like that. But we believe that in order to increase access to these services, they need to be provided by them. And so the task shifting has been implemented with advocacy. And we have been blessed by having local champions such as the person you've seen on the photo, and Professor Papan, or the princess. You may not have princesses in your country, but I hope you can identify some local champions that can help you bring the country to this level of sustainability. So the Ministry of Public Health, under the leadership of the minister, the former minister, has just allowed and approved KP lay providers to perform HIV counseling and specimen collections for HIV, STIs, and rapid and point-of-care test, ART, and PrEP dispensing. So that was a huge lift. And hopefully will increase access to services in Thailand. And then there is a lot of effort in establishing capacity building processes that can then help to certify nationally to these lay providers that they are trained, they have the quality and credibility in, to provide those services. And then we inform the national, so we work in cycle, so we inform the national health security that these people in the roster, they are providing these services, and then so it confirms the national health security that it is okay to finance, to continue to finance them. So that this is the circle of financing model. And then further, Thailand has just recently explored new frontiers in sexual reproductive health services with the private sector, with the hope that wherever you are, which in the societies, whether you have less money or a little bit more money, you will receive tailored services in different locations. So the Thai Red Cross Anonymous Clinic, and I think you will all know well, who has been providing HIV services since the beginning of epidemic in Thailand. Then it will be expanded, the comprehensiveness of the services will be expanded to these private sector, hopefully that some people, friends and colleagues in university and somewhere who may not be willing to go to the community side will go to the private sector sites such as this. We don't know the results yet, but we have started to explore that option. So here I would like to show an example of Vietnam. Vietnam has introduced social health insurance, or SHI, to cover ARV in the country. So the government selected 188 sites and beginning to try to cover 48,000 patients, enabling them to have free ART. So USAID has been providing support in 31 HIV treatment facilities, covering around 4,000 people, training and bringing the clients and healthcare providers together in order for them to understand the reimbursement process and mechanisms and how they can register, and allowing the smooth process for this to benefit the larger group of people. So in the different district level, they have been able to increase domestic finance through these different mechanisms. And this mechanism has been found in many countries in Asia also. And I think my colleague from WHO will elaborate a little bit further. So what is the lessons learned in Vietnam? In Vietnam, the success really lies with the government. Again, perhaps similar to China. the government is really committed to supporting ART and allowing the establishment of social health insurance for the most marginalized and stigmatized population, and that is the people who inject drugs. So this is a huge significant example that we should all look at and congratulate the government of Vietnam. There's still a challenge in terms of ensuring that the system put in place can be supportive to larger population, allowing them for different options of payment, whether it's a full payment or co-payments, so that it helps to sustain this mechanism. So this slide really is a reflection from the one of the clients. So I decided to put this because it reminds all of us. I think it reminds me in particular that what we are doing here is again, Eamon mentioned already about people-centered approach, and my focus, my suggestion in this slide is that we all need to be reminded that we need to follow client-centered approach. So if we are receiving services, what kind of services we would like to have, and then we should all have that duty to provide those services to them. So in this case, if ARV is covered fully by the government, so the patients will then have the freedom to come to the services. They don't have to have fear whether they will have money to cover their treatment, and the impact on family will be zero. So, so here my concluding slides is the ways forward. Financial transitioning from donor to domestic financing needs to be planned as early as possible. As I said, in some countries, if there are political issues and that is beyond our control, it could happen that the donor leaves quite abruptly, and that will have significant on the well-being, on the lives of the clients that we are serving. So we need to ensure that national laws and policies and guidelines are supportive and are there to support task shifting, allowing civil society organizations or key populations in the concentrated epidemics such as this in Asia to let them serve their friends and their colleagues and their communities. And the success in achieving the UNA's 90-90-90 goals by 2020 and eliminating AIDS by 2030 will be associated with our capacity to put fast-track solutions. We have tools that we know of. We have PrEP, we have HIV testing, we have same-day ART. We have many things that we can put in the hands of those in which they can have the greatest impact, and that is civil society organization and key population. We need to explore a variety of financing mechanisms to channel funds to HIV programs, and that includes engaging private clinics or private sector or hospitals. Social contracting is a promising financing strategy for governments to provide funding to civil society organizations and KP-led organizations for health service deliveries. Countries can learn from each other, and I hope that we are all learning from each other here on various strategies. Whether it's about grant management, reimbursement per person tested or treated, and social contracting can also be used to engage with CBOs to rapidly implement emerging and more effective interventions, including index testing and PrEP. So finally, countries will need to find their own solutions to funding KP programs. So these mean that more investment in implementation science could also be considered. We need data to support advocacy for financing to happen. Countries which have strong CBO traditions or having strong civil society organizations providing services will likely find it easier to provide specific KP services and to finance these. So countries also need to address stigmatization of key populations in government and in the society. They will need to embrace social contracting mechanism to meet the specific needs of key populations in order for all of us to engage in time. So thank you very much.
Thank you very much for the sharing the experience in